I'd like to introduce our next speaker, someone I know very well. Norman Sussman is Associate Professor of Surgery in the Division of Abdominal Transplantation at Baylor College of Medicine. He also serves as a clinical investigator, sub-investigator for advanced liver therapies at St. Luke's Episcopal Hospital. Dr. Sussman is board certified in gastroenterology, internal medicine, and transplant hepatology. He earned his medical degree from the University of Witwatersrand Medical School in Johannesburg, Republic of South Africa. His extensive training includes internships in internal medicine and surgery at Johannesburg General Hospital and senior house officer positions in medicine and pediatrics at St. Charles Hospital in London. Following his time in England, Dr. Sussman completed an internship and residency in internal medicine at St. Louis University Hospital in Missouri, where he also served as chief resident. He completed a fellowship in gastroenterology at Washington University School of Medicine in St. Louis. Dr. Sussman's clinical interests cover all aspects of liver disease. His research interests include assessment and management of acute liver failure, artificial liver support, and new agents to treat viral hepatitis and complications of advanced cirrhosis. Let us welcome Dr. Sussman.
Well, thanks, Chad. I was basking in the glow there. I almost forgot to come up. What Chad was saying is I was a very slow learner, and eventually, by the time I did the third boards, I got a special certificate from the ACGME thanking me for all the money I sent them. Is this the changer? Okay. Well, I have to say, I thought Jules' talk was one of the most exciting and interesting talks I've ever attended, so don't expect that a second time on the same program. When Chad asked me to speak, Chad and I have become friends. I lived in Salt Lake City for 2 years, and it was 2 of the best years of my life. I really enjoyed it. I made wonderful friends. The skiing is a lot better here than in Houston. For those of you who didn't know it, don't visit for the skiing. And the other coincidence is that Chad mentioned I did my training, part of my training, one of the many places was St. Louis University, where I met Joe Anderson, who's an allergist in town. And so actually I've been coming to Ogden probably since the 80s, because in the days before I could really afford anything, I could stay at Joe's house and go skiing with him. So I've enjoyed living here a long time. It was a nice coming home. I'm showing you a picture here of Texas. There's a big red star there. That's Houston. You see we're right on the Louisiana border. I've drawn it especially big because we think it is a very important state. It is a huge state. There are, as an example, I've recently been looking at hepatitis C. There are 400,000 cases of hepatitis C in Texas. That's more than all the people living in Connecticut. Okay, so I have no conflict of interest. As my lawyer says, if there's no conflict, there's no interest. And also, if anyone can think of some way in which I could have a conflict related to this talk, please let me know. I'm always interested in hearing about that. So I wanted to tell you how a hepatologist looks at liver tests. And I think it's fairly routine. What's interesting is I have a big group. I work in a group of 5 hepatologists, 5 full-time, 2 part-time. And in conferences, there aren't a lot of differences of opinion except in the minutiae. And so generally people will come to the same conclusion. And this is just practice. It's not because hepatologists are particularly brilliant, but there's a way of looking at them that I think will help you. And I'm going to give you an overview that will help the internist and the gastroenterologist. So it gets a little dense at times, and if more than 50% of the audience falls asleep, I'll stop at that point. Okay, so the first question you want to know is, are you dealing with acute or chronic liver disease? So it's interesting how many people get sent to us with acute liver failure. I recall a a nurse in her 50s from Brownsville came up. They sent her because she had acute liver failure. When she came in, she had low platelets. She had a couple of other things that suggested maybe this had gone on longer. We did an ultrasound, eventually a biopsy, and she had advanced fibrosis. So she had two diseases. She had acute hepatitis E superimposed on this. So always look at whether you have an underlying liver disease. You can easily be fooled. By the same token, someone who comes in with an acute viral, say a CMV hepatitis, may have low platelets, and so they get sent in as cirrhosis when in actual fact this is an acute illness. So the first question is this acute or chronic? So how do you tell with cirrhosis? Cirrhosis, I look at two things. The most useful test, if you gave me one test only, I would say look at the platelet count, because almost everyone with cirrhosis is going to have a low platelet count. So that's step number one. Step number two is always get an image. If the insurance bulks, get an ultrasound. If they're asleep at the wheel, get a MR or a CT scan. We do more MRs. It depends a little bit on your local radiologist. If the radiologists are very comfortable with MR, that's what you should do. If you have a very good MR machine, there's a huge variation. Don't get an open MR because they don't give you a very good picture. And don't get a non-contrast study because the liver, you really need contrast to make the diagnosis. Then I look at what tells me if they're chronic, chronicity and severity. Well, chronicity, there is nothing better than getting some old labs. I saw a young guy yesterday, he's a nurse practitioner, abnormal labs, and we're puzzling about what this is. And then he says, oh yeah, I remember I was doing my training at the VA 2 years ago. My labs were totally normal. That completely changes the differential diagnosis. And he has something acute. It's most likely a medication he's taking. Also look at the albumin and the bilirubin and the INR. Those will give you a sense of how well the liver is working. I'm going to deal with those separately. Then look at liver injury. So liver injury, when you damage a liver cell, ALT and AST are going to leak out. And so the more that's leaking out, more or less, the more the injury. There is not a very good correlation between what you see on the biopsy and the level of the ALT and AST. The other thing is we assume damage 100 cells, you get a certain level of ALT, but there is a possibility that we among us have different levels of ALT in our cells, and that's actually never been explored. So we make this association, but we don't actually know the answer to that. Having said that, with acute liver injury, we usually see ALTs in the same range, making us think that more or less this is a fairly constant number. Then also look at cholestasis, and I'll address this next, but the ALK-Phos measures cholestasis. Now, if you get some liver injury, you usually will have some obstruction to bile flow just because the liver is collapsing and bile is not getting out very well. But the higher ALK-Phos, especially if it's disproportionate to the amount of ALT and AST elevation, is going to direct you towards the bile ducts and away from primary liver injury. I put in the other two, GGT and 5' nucleotidase. So GGT, pediatricians love GGT because it goes along with ALK-Phos. I'm going to go into a little more detail, but GGT is inducible, especially with alcohol. So I know I'm in Utah right now, and so I don't have to worry about that, but is that true? For adults, GGT can be a little misleading. It can be induced by as little as one drink. So there's a backup plan, and that's the 5' nucleotidase. You don't see this very often on your panel with your checklist, but that's a very useful adjunct if you're wondering if the ALK-Phos comes from the liver. Biliary imaging is sort of a specialized area. By the time you get to this point, if you have a cholestatic picture, make sure you don't have dilated bile ducts. You can't guess which it's going to be, and you always must exclude them. Ultrasound is quite useful, except after transplant. MRCP is used more and more, and eventually you may need an ERCP. We don't do that as our first test, and I don't do ERCP at all, so again, I have no conflict of interest, but if you really need to know, the ERCP may be what you need. So the second question, is this hepatocellular or cholestatic disease? So I've put this ridiculous formula up. Okay, this is not rocket science. You'll see that you've got ALT of upper limit divided by the upper limit of normal over the alk-phos divided by the upper limit of normal. And this comes out of a textbook, so it can't be wrong. So if you have, so all this says is if your ALT is more than 5 times the upper limit of normal and your alk-phos is about 2 times the upper limit of normal, this is going to be hepatocellular injury. And so I just look at them and I say, if the ALT is 400, that's about 10 times the upper limit of normal, and the alk-phos is 200, that's about 2 times the upper limit of normal. This is liver injury. This is not cholestasis. But I've also put something else at the bottom that you should notice, and that is the AASLD, the American Association for the Study of Liver Disease, came up with this campaign called What's My ALT? So what is a normal ALT? If you look at your lab, it will tell you normal ALT is below 42. If you go to San Antonio and Brooke Army Base, that lab will tell you that the normal ALT is less than 65. Now, what is the difference there? The difference is a lab calls in volunteers, gets their blood, and measures their ALT, and then says, we're going 2 standard deviations from this number. So if I went down to a drug house where everyone had hepatitis C, my median ALT might be 80. If you take people who have absolutely no risk for liver disease, you prove that they don't have hepatitis A, B or C, that they're not overweight, they don't have metabolic syndrome, and you measure them, women's ALT will always be less than 19. In fact, in Asian women, it's probably less than 12. And what do you think happens to your ALT as you get older? Nothing. So if your ALT was 12 when you were 12, it should be 12 when you're 72. And so there is no change other than liver disease. And so it's very important now when people come to me and they say, my doctor said my ALT is normal, I still want to know what that is, because there is still this tendency for physicians to look at the normal and say, oh, it was 65, that's normal in this lab. It's not. So be careful about that one pitfall. And so for men, it's less than 30. For women, it's less than 19. And when we get patients with hepatitis C on an effective drug, you'll notice the ALT drops dramatically during treatment. And if they're cured, it stays down at this new level. Okay, so AST used to be called SGOT, and ALT used to be called SGPT. And some labs still put that in, but the nomenclature really has been ALT and AST for at least the last, 25 years. So I don't know why the labs persist with this. So ALT is more specific to the liver. So when you get generalized liver injury, if you get a patient in with rhabdomyolysis, they're going to have a much higher AST. Sometimes people with an invasive tumor in the liver will have a much higher AST as the tumor is damaging. It's damaging the liver cells, but there's more tumor death. So it's something to look at. I don't find that a terribly useful thing. But the ALT is usually higher in things like viral hepatitis, autoimmune, non-alcoholic fatty liver disease. As they switch to cirrhosis, AST may go up. Okay, so when you see this reversal, there was a former chief of GI at the University of Utah who swore by this. It is not as effective as he would have liked to say, but it's probably fairly accurate. If you see an AST to ALT reversal, think that the patient might have cirrhosis. It's a hint. Alcohol. Alcohol causes pyridoxine deficiency, and so alcoholics typically have a lower ALT. It's not that the AST is higher, it's that the ALT is lower. And so when you see alcoholic liver disease, AST ratio 2:1 over ALT, that tends to point you towards cirrhosis. But I'm going to show you a separate instance, and that's the early phase of acute liver injury. And then, as I mentioned, other organ damage is going to give you the high AST. So if you damage your muscle or my patients generally don't have a brain, but if you damaged your brain, that might do it too. Okay, so this is actually one of the pieces of work that I accomplished. I would like to say I accomplished it. This was really the math department at the University of Utah. I was fortunate enough to run into 2 brilliant mathematicians who helped with this. So we had noticed that when people come in early with an acetaminophen overdose, very early on, the AST is always twice the ALT level. The peak is always 2 times AST to ALT. But AST clears at 50% per day, and ALT clears at 30% per day. And that means that if you give someone two values, you should be able to tell where they are in their overdose time. And so I'd been sitting there thinking, how do I do this? I went to see these mathematical guys who said, oh, that's easy. And they drew this curve. So this is a nomogram. This is not actual data. And we based it on the fact that the peak is about 48 hours after the overdose. And then there is a rapid change so that after that peak, all you need is those two numbers, and you'll be able to tell the time. And so I showed you the differential clearance. They equalized about 96 hours. You'll see the two lines cross over. Now, if you integrate those with the bilirubin and the INR, you can come up with a fairly attractive model about your chance of surviving. And so here we have a thing called MALD, M-A-L-D, which sounds suspiciously like MELD. We thought we'd ride on the coattails of MELD. Stands for Model of Acetaminophen-Related Liver Damage. You'll see the first author is Chris Remian. Actually, he goes by Ramin. I thought it was French. He said it's German. Ramin. And what we're showing you there is 4 graphs. On the top left, is the ALT. Here's AST. Here is INR and creatinine, and you'll notice the dots are the actual numbers, and the lines are the predicted numbers, and you see how closely they match. This shows you that you can very accurately. So when I get an acetaminophen overdose, someone calls from an ER, Texas, it could be 800 miles away in El Paso. I ask them those couple of questions. What's the creatinine? What's the bilirubin? What's the ALT to AST ratio? If it's already switched over, if AST is already lower, I know that we're at least 3 days out. And then I just care what's the INR. If the INR is already coming back to normal, the patient's going to survive. So this was a very useful study. We're studying it further. But here you see in this particular patient a predicted death is on the right side, predicted survival is on the left, and you see that this orange dot is on the probable survival side. Small risk of death, but by and large, this patient will survive. So that's a very, very useful quick test for you when you get called from the ER to say, what is that ratio? Okay, so now from the sublime to the ridiculous, I'm going to try to explain to you how I think about cholestatic liver disease. So I'm going to start out by showing you a bile canaliculus. So the bile canaliculus is shown here in the middle, labeled BC. At the top and the bottom, you see two J's. These are junctional complexes. And I'll show you why that's important. And inside that, you see a lumen with microvilli. This is what a bile canaliculus looks like. Here it's stained. This stain is actually for alkaline phosphatase, and you see that the alkaline phosphatase runs between the cells in these tiny channels. Here it is by scanning electron microscopy. There is a canaliculus. This is the blood side. Here's an endothelial cell. And if you inject resin into the bile canaliculus backwards and then dissolve away the rest of the liver, you see this very dense network, and these are these tiny channels that run between hepatocytes. So it's a very dense network of channels, and they eventually come together in the canals of Herring and go into your bile ducts. So why am I telling you all this? Because, well, I don't know, because the liver is an epithelial organ, and all epithelial cells are oriented with a top and the bottom. So the easiest ones to understand are kidney or intestine, where you have a lumen, and if you cut the lumen open, you have this flat thing that you can lay out, and it has a bottom over here and a top. The top is the brush border. The bottom is the basolateral membrane. In the liver, there is no top and bottom. It's just the space between the cells. This is the equivalent of the lumen of your hepatocyte. The reason I mention that is because alkaline phosphatase is located exclusively on the lumen, but it's on the lumen of everything. So if you stain the intestine or the kidney, you're going to find alkaline phosphatase on the lumen. How does it get into the liver? So this was a topic. I once got a grant for $350,000 to study this. That's your tax dollars at work. But I wouldn't be giving you this talk otherwise. So here is what happens with proteins that are made in the cell. Alkaline phosphatase goes directly to the lumen. But in the liver, alkaline phosphatase goes first to the blood side and then to the lumen. So there's indirect targeting. So how does it know where to go? Well, there is a class of proteins called pigtailed proteins. It stands for pig-glycoprotein anchored proteins. The pigtailed proteins, instead of being bound into the membrane by a core of protein, so membrane-bound proteins have a lipid-soluble segment that holds them in the membrane. Otherwise, they'd be rejected. Well, instead of being tied in there with a piece of protein, it has this peculiar tail called this phosphatidylinositol glycan. And because it's indirectly targeted, when it gets to the membrane, to the blood side membrane, there is a phospholipase. There's a phospholipase that cleaves it right over here. So protein, when you have cholestasis, your proteins that are pigtailed go to the blood side and are clipped off, and that's how they end up in the serum. So the mechanism for alkaline phosphatase going into the serum is because it's indirectly targeted and there's a phospholipase C. Well, interestingly, the GGT and 5' nucleotidase have the same pigtail, and therefore the same mechanism exists for all three, and that's why all three go up at the same time. So that gives you some explanation as to why these three proteins would be useful in measuring cholestasis. So located in the bile canalicula's, there are three genes. When I say to the residents, tell me the three genes, they say liver, kidney, bone. Well, liver, kidney, bone is actually one gene. There are two others. There is an intestinal gene, which is how I got my $350,000 grant, and a placental gene, which for some reason we've evolved a third gene. Does anyone know what ALK-Phos does? No, nobody knows. We know people with deficiency do very badly. They have severe bone disease. We know that alkaline phosphatase from E. coli is 50% homologous with human alkaline phosphatase. So it's been very important for the entire evolution of living organisms, and yet we don't know exactly what it does. It probably does more than one thing. But this liver, kidney, bone is one gene, and it's just glycosylated differently by the different organisms, by the different organs. And so your liver puts a certain kind of sugar on, your intestine puts a different one on, your kidney puts a different one on. And that's why you have to be very careful when the lab says to you, I can fractionate your alkaline phosphatase. Unless they're very experienced, those are so similar, they're very difficult to distinguish. And so I recommend you do the GGT and 5' nucleotidase rather than trying to fractionate the ALK-Phos. If you speak to your lab and they know what they're doing, it is worth fractionating them. Okay, so that was a really long climb for a short slide. Would you agree? Okay, but you probably know more about ALK-Phos than anyone else in the country right now. Okay. The other little tidbit is alkaline phosphatase is low in patients with Wilson disease. So if you see a patient with chronic liver disease and for some reason their ALK-Phos is surprisingly low, think about Wilson disease. This came up 4 times in 120 questions on the liver boards. So for those of you preparing for that, that's something you should see. Okay. All right. What about albumin and AFP? So these are proteins that are made by the liver. AFP is the fetal analog of albumin, and so it's made, so AFP and albumin are on the same gene, and genes are turned on and off by signals that we call transcription factors. So because they share the same regulatory space, you can only transcribe in one direction or the other. And so any one cell can only make ALK-Phos, can only make albumin or AFP. It can't make both. So this switch is very important. It's important in a lot of things. I'll give you a little more information on that. But it's turned on when cells become fetal. So when do liver cells become fetal? Well, they become fetal sometimes when they turn into cancer. So hepatocellular carcinoma may give you a high AFP. More commonly, You see it in people with hepatoblastoma. Joel mentioned hepatoblastoma. There's a fetal tumor. Now, the fetal tumor, these cells look just like fetal hepatocytes, and they have an over 90% incidence of elevated AFP. We don't see them in adulthood. They're pediatric tumors. In cancer, we see elevated AFP probably less than maybe 30%. So at least 2/3 of our tumors do not express AFP. The reason is multifold. AFP became popular as a screening test because in Asia, it's more effective. It is more accurate in Asians, but if you look at Asian cancers, they're more frequently driven by growth factors and hepatitis B, whereas our cancers are more frequently driven by cirrhosis. And so it's much less common. So you cannot count on AFP as a screening test, although I do find it helpful as an adjunct. So AFP is the fetal analog. It's made when cells revert to a fetal phenotype, and this is a coordinated switch to the fetal gene. So there's not AFP is only one of a series of fetal genes that get turned on during cell division. So when does this happen? If you damage the liver, what happens to the hepatocytes? This is not like scraping your skin. If you scrape your skin, your basal cells will grow and replace the skin. But in the liver, if you do a 30% hepatectomy, all of the remaining cells will enter the cell cycle. It's a coordinated response. So every cell there behaves like a stem cell, and the entire liver undergoes regeneration. And during regeneration, it behaves like a fetal cell. So if I show you a Tylenol overdose 3 or 4 days later as they're recovering, you may find an AFP of 400 or 500 as the entire liver is regenerating, and that will rapidly fall off. Okay. The danger with albumin, though, we always look at albumin as a marker of how's your liver working. So the other signal for switching from albumin to AFP is inflammation. And so if you have a strong inflammatory component, your albumin may be low, your AFP may be a little high. That low albumin doesn't really reflect residual liver. It reflects this inflammatory state in your liver. And so that's a very important thing to remember. People equate albumin with how well is my liver working. If your liver is shot, your albumin's going to be low. But if you have acute inflammation, and we see this in Tylenol overdose all the time, we see this in severe hepatitis, the albumin will go down. When the inflammation settles, the albumin will come back up. All right. So prealbumin. Who here measures prealbumin? What the heck is prealbumin? What is prealbumin? So when someone asks me what's prealbumin, I always ask, who's asking? Because I used to have a biochemistry lab. And so prealbumin in those days was the pre-synthetic form of albumin. When when any cell makes a protein, it makes a pre-form of that, and that little tail that it makes directs that protein somewhere. So it's either going to stay in the cytoplasm, or it's going to go to the membrane and be anchored as a membrane protein, or it's going to be secreted. So a lot of proteins are made with a tail, and the albumin is one of them, and it's made as prealbumin. However, the prealbumin that we measure is not named for the biology. It is named because in the old days, when we had limited tests, people would run protein electrophoresis. And there was a spike just before albumin, and that was called prealbumin. In fact, it's not prealbumin at all. It is transthyretin. And transthyretin gets its name because it transports thyroxine and retinol. What does it do? I don't know what it does. It transports stuff. It's a transport protein. But, very important, misfolded transthyretin is actually the major protein it's the most common protein in amyloid. So making excess is a cause of amyloidosis and is the most common cause. The prealbumin is used as a nutritional assessment because it turns over very rapidly, but the same as with albumin, it is affected by inflammation. So inflammatory liver disease is also going to give you a low prealbumin. So don't equate it 100%, although it is usually very low in people with severe nutritional deficiency. But don't forget, severe nutritional deficiency can cause inflammation, and inflammation can cause severe nutritional deficiency, and those two frequently go together. All right. So bilirubin transport. This is getting worse and worse, isn't it? Okay. So bilirubin. So where does bilirubin come from? It comes from breakdown of hemoglobin. Here's hemoglobin. Globin goes to heme. Heme goes to bilirubin, and then it is taken across by this transporter protein over here. It is bound to ligandin, which is the L. The ligandin, bilirubin ligandin complex, then is glucuronidated. And this is UDP glucuronide transferase. So what's the difference between this bilirubin and this bilirubin? The difference is one is lipid insoluble and the other is lipid soluble. And so when I was a resident, we used to refer to conjugated and unconjugated bilirubin. We now refer to direct and indirect, and I'll tell you why that is, why we change. These are, if you were to take this picture, this is unconjugated, this is conjugated. Interestingly, you need conjugated bilirubin in order to pump it out of the cell. Bilirubin that is unconjugated doesn't have a pump. It needs to be conjugated to glucuronide. And that's what this carrier protein is over here. The other interesting thing is, why do you need to conjugate it at all? The problem is that you have a 4-ring structure called a porphyrin that is left over when you break down hemoglobin. And when you break that open, because of the enzyme we have, it makes a molecule that is hydrophobic. If that enzyme had acted anywhere else on that ring, you would have a hydrophilic molecule and you wouldn't need this elaborate machinery to get rid of your bilirubin. You would just pass it on your urine. But no, for some reason, we have developed this very complex system. It sounds kind of like Medicaid. It's a very complex system that really achieves a goal eventually in a much more complicated way. It is but because of where we break that porphyrin ring, we need a supplemental system to bind the bilirubin. And so here you see this carrier over here. This is the bile canaliculus. So in liver injury, we tend to see a high direct bilirubin or conjugated bilirubin. And why is that? You would think if your liver was damaged, bilirubin would stay on the outside here, and you would have a high unconjugated bilirubin. In fact, I thought that for years. Lucky I got to give this lecture. I figured it out eventually. You would think liver injury would result in poor conjugating ability, and you would end up with unconjugated bilirubin. But it turns out you have massive excess of all of these except for this carrier here. And therefore, even with severe liver injury, the bilirubin you see is mostly conjugated and therefore mostly direct. So let's talk about how you get direct. So bilirubin is this organic anion derived from hemoglobin, and we measure it by a thing called the Vandenberg reaction. It's a diazo reaction. And so how do we do that? We take some serum, and we add the dye, and we watch for color development. And whatever develops directly is called direct bilirubin. Then we add alcohol, get the rest of that insoluble bilirubin into solution, and repeat the test again, and that's our total. And the difference is the unconjugated bilirubin. So the indirect is albumin bound, and the direct is this water-soluble fraction that goes into urine if it gets back into the bloodstream. Why do we always see a little bit of direct? If I were to take normal serum, I would say mine, but there's no telling if I'm normal. But if I took normal serum, I might still find a little bit of direct. But if I did it by HPLC, there would be no direct. The thing is that this is a messy reaction. The diazo dye reacts with things even that are bound. They just don't react quite as well. And so you're always going to see somewhere between 5 and 10% of your bilirubin as direct, which if you actually measured it biochemically, it would not be there. So you need to know that about this diazo reaction. It's a bit of a leaky test. We do it because it's cheap, it can be automated, and there's 50 years of history of using this test. But if you refer to your direct bilirubinemia, you're really saying this small amount of direct that appears normally is not really There, it is just there as a leaky aspect of the assay. So nobody does routinely HPLC for bilirubin, although pediatricians do it because they're worried about conjugation genetic defects, and there it is important enough to do it. But in the adult labs, you'll never get that result. So that's that. Then we have this thing called delta bilirubin. Delta bilirubin is bound to albumin, and it is covalently bound, so it doesn't clear until the albumin clears. So if you have a patient with a cholestatic disease and you notice 2 weeks later they still have some bilirubin hanging around and you're wondering what it is, it's bound to albumin. It's just going to take a while for it to clear. So you shouldn't worry about that as long as it slowly goes down, and goes down over about 4 weeks. So I've mentioned why liver disease gives you conjugated bilirubin because of the deficiency of the transport protein. And then the other little tidbit I thought I'd throw in here is when I see a patient with severe jaundice and no apparent liver abnormality, they almost always have right heart failure. And I don't know the reason why. I've not been able to find out why, but people with severe heart failure frequently have jaundice, and it sometimes is very persistent, and no one knows the reason. And this can happen in what appears to be the absence of liver injury. They usually have congestion, but not real injury. Okay, so I promise this is the last time I'll do this to you. So I mentioned this just because there may be some pediatricians and people who take care of kids. There has been a huge growth in our understanding of these familial cholestasis syndromes. So we don't see this as adult hepatologists, and I really had to stretch myself to include this. But I got talked into giving a lecture to the students, and that's how I found out about this stuff. So here you see the sinusoid, here's the cell, and these are the bile canaliculi. And what I'm showing you over here is bile acids. This is BAZ, and this is BA bound to Y. These are two carrier proteins that carry bile acids. So remember, bilirubin is different from bile acids. Bile acids are these organic acids that go along in bile all the time, and we ignore them as adult. So if there are pediatricians or family practice people here, this is something you need to know. And the pediatricians check bile acids all the time. So this conjugation here, the Z stands for taurine. I put these in your slide set so you would have them as a reference. And the Y over here stands for sulfate or glucuronate. They have two different transport proteins. So they come into the cell either pre-conjugated or conjugated in the cell, and they have two separate transport proteins that take them into the canaliculus. So your bile acids in your cell are not very good for you, and they have to get into the bile duct. And they're transported actively. This thing here is called MRP2, which stands for multidrug resistance protein 2, and this stands for BSEP, which is bile salt excretory protein. I like that one because I can remember it. It's bile salt excretory protein. Here's an organic anion transporter, OATP1, and the reason we're all going to need to know about that is the new antiviral agents, some of them are inhibitors of OATP1 and therefore produce high bilirubin, which is quite benign and reversible. So OATP1 is going to come into your vernacular more frequently. Okay, and so here is a summary of what we know about pediatric cholestasis. So some of you may have remembered, I sort of vaguely remembered there was a thing called progressive familial cholestasis, progressive intrahepatic familial cholestasis, and now we have genes for most of these. And so here you see what is known as PFIC1, is progressive familial intrahepatic cholestasis type 1. Here's PFIC3, here's PFIC2, and each of them is associated with a bile salt excretory protein problem. And so there is a lot more biochemistry at our fingertips now than there was when I went into gastroenterology, and believe me, this was a strain to get because these things come up in the liver boards as well. Okay. So what about coagulation factors? We love coagulation factors. PT-INR. INR is PTT has almost no utility to us. There's no real reason to get a PTT other than you might do it one time because people may have a lupus anticoagulant, and there are very, very rare people with a significant coagulopathy that have an abnormal PTT. But from a liver standpoint, it's almost useless. But the PT-INR is factors 1, 2, 5, 8, and 10. The prolonged PT-INR can be congenital. You could just have a deficiency of one of these factors. We see it in liver failure. It's really quite common. We see it in vitamin K deficiency and in warfarin. Warfarin, of course, induces vitamin K deficiency. The interesting thing about these enzymes is they're made in zone 3. So zone 3 of the liver is the area furthest away from the canaliculus, closest to the central vein. That's the area where blood flows from the canaliculus, from the portal tract towards the center, and it's the area with the lowest oxygen tension and the area where there's certain enzymes. And so when we get Tylenol poisoning, for example, we preferentially kill off zone 3. Well, zone 3 is where all the factors are. So if I see a autoimmune hepatitis with an INR of 5, I may faint. But if I see a Tylenol overdose with an INR of 5, that's pretty normal. Those people really are not in big danger. So the cause is going to have a lot to do with the result. The same thing happens in heart failure. Because you're congested around the central veins, that area is preferentially damaged, and again, you may see an elevated INR in people with zone 3 injury. The two typical ones are heart failure and Tylenol overdose. Now here is vitamin K dependent, 2, 7, 9, and 10. So 2, 7, 9, and 10. Factor 5 is not vitamin K, not vitamin K dependent. So if you're wondering about whether someone's coagulopathy is caused by vitamin K deficiency, you could check the factor 5. That's one way of doing it. Of course, a cheaper way is to give them a little vitamin K and see what happens to them the next morning. So depending on your lab and what they're willing to do for you, you can make this distinction. And I can't read what's on that bottom line. I'm sure it was very important. All right. Okay, so ammonia. Who here works in the ER? ER doctors love getting the ammonia. They'll call me at 3 a.m. and they'll say, the ammonia is 81. And I will say, what's normal? Because we don't really check the ammonia very often. And it's quite variable. Sometimes it's 50, sometimes it's 80. Even in our lab, I see some variation. The problem with ammonia is it's not that helpful. For one thing, it changes over time. So if you draw an ammonia in your office, and so depending on the lab, so CPL is a big company in Houston, and they send their labs overnight to Austin, where so Austin is a suburb of Houston. It's 150 miles. And by the time it's sat overnight, the ammonia has gone up. Ammonia changes with time. So if you really want to get a good ammonia, you probably want an arterial, and you want to run it right away. So now the question about whether venous is accurate, some experts think venous is not that much different. And so the bigger issue is time, not where you got the blood from. So we don't check the ammonia very often. We do occasionally, and occasionally it's sort of thrust upon us because someone will get it, and then we'll say, okay, now we've got a high ammonia. But every now and again, someone turns up with a urea cycle defect. It more frequently occurs in women. And the classic example is a woman in her late 60s or early 70s, and her friends think she suddenly started drinking because she appears drunk, even though her whole life she's been a teetotaler, and everyone's kind of whispering about her, and she turns out to have a urea cycle defect, and she's a heterozygote, and so she just doesn't metabolize ammonia very well. So there it is quite useful. We had a very interesting patient at the University of Utah. One of the fellows wrote this up as a case report. Someone who presented twice with acute liver failure. The first time it was diagnosed as Bactrim overdose, Bactrim toxicity. And the second time she was pregnant. And the the obstetricians are very attuned to this. The obstetrician got her ammonia. It was about 400. So even though I don't know the normal range, I know 400 is kind of high. And she turned out to have a urea cycle defect. So it is something to keep in the back of your mind, because every now and again you're going to see someone like this. And she had acute liver failure. And the first time she went to a transplant program, she was almost transplanted, but she got better and they didn't know why. And the reason is because she didn't get any protein and she got a lot of glucose, and it solved her problem. And so people with urea cycle defects can't handle protein, and that's what put her into failure the second time. And so I've left you with a diagram here of the urea cycle, and you see this is, I know you're all fascinated by this, but this is called the urea cycle here. I spared you the problem of writing down all the enzymes, but I put this in for another reason, and that is there is a second way of getting rid of ammonia. And that is this alternative pathway through phenylacetylglutamine. And I've shown you over here sodium phenylbutyrate. Anyone ever use sodium phenylbutyrate? No, because you're not pediatricians. Pediatricians use it for urea cycle defects because it takes this ammonia and shunts it into this alternative excretion into the urine. So the value to us is maybe we could use sodium phenylbutyrate to treat hepatic encephalopathy, which has a high serum ammonia. Well, the problem is you need about 25 grams of sodium every time you do this, and so for cirrhotic patients it doesn't work very well. But last year, an early release of a glycine molecule, so a glycerol phenylbutyrate has been developed, and we may find that it's actually quite effective in treating hepatic encephalopathy, and so we may see that coming to the market. A phase 2 trial is underway, and so in the future, you'll be able to pull this diagram out and say to your patients, well, you know, this side, we're having a little trouble with the urea cycle, but we may be able to use the alternative excretion pathway. Okay, MELD, I think everyone is familiar with this, but just to briefly point out where it came from, this is the formula. I carried in my head. Anyone here use a log table? Anyone remember ever using a log table? I used to have to use them. I see a couple of the old dudes there. I remember, I thought this was the most brilliant thing, the log table, my God. But this formula was developed to see if it was worth doing a TIPS in a patient with cirrhosis, because if a patient had a high MELD, the chance of dying after TIPS was very high. It was then extrapolated to transplant and became the basis for organ allocation after February 2002. Made a huge difference because instead of just going by time, we went by the sickest patient getting a transplant. And there is a finer definition of this, but just for simplicity, I've put in here is your MELD score. So it's based on your creatinine, bilirubin, and INR. It was meant to be so you couldn't cheat, because it used to be if someone was in the ICU, they would get listed as a priority. So, you know, I'd call up Mrs. Smith and say, hey, Mrs. Smith, it happens I have an ICU bed, come in. We'd list her as a 1A, and she'd get a transplant. So people didn't like that. So we went to this. So the basis of this is your 30-day mortality. This gives you your 90-day mortality. This gives you your chance of surviving 90 days. If your MELD is greater than 40, your chance of surviving is almost 0. And so the higher this number, the more likely you are to die, and therefore that is how we prioritize patients for transplant. And so you'll hear people talking about the MELD score, and it's on Hippocrates, and so so I don't actually check out the logs, I just use Hippocrates. Well, the patients somehow think it's very clever. Okay, so there was a thing called MELD sodium, MELD NA, and what's the big deal with sodium? And so here is something, I'm actually going to tell you one useful thing in this talk. Okay. We give people a 2-gram sodium diet, and that wasn't an accident. We found out 2 grams is 88 millimoles, and most people can excrete 78 millimoles in urine, plus 10 of involuntary losses gives you your 2-gram diet. So people who are on a 2-gram diet should be excreting no more than 78 millimoles. So patients who excrete greater than 78 in 24 hours can be treated just with a sodium restriction. Now, I'm sure things are different here in Utah, but I cannot get people to stick to a 2-gram sodium diet. And how do I prove to them that they are cheating? Well, one way is you can assess 24-hour urine sodium. So that's very easy. Well, it's not as easy as it sounds, but you tell them, I need a 24-hour specimen. They invariably lose some of it, and they do it twice, and eventually they get it right. And you compare that to the creatinine, 15 milligrams per kilo for men, 10 for women, and you can see if they've excreted that amount. If they're excreting more than 78, they got that from eating it. They can't make sodium, and they always say to me, no, I didn't touch it. And I said, well, you're excreting 4 grams a day. Where did it come from? Houston's pretty humid, but there's not much salt in the air, and so you can't get that from anything other than diet. But here is the useful trick. If you do a spot urine, and the sodium is greater than the potassium, the patient is excreting more than 78 millimoles per day. That is the most useful test, the most useful thing I can tell you, because in one spot test, you just do the sodium and potassium, it's about 90% accurate in predicting how much sodium people are taking. Now, it doesn't work during the equilibration phase. If someone is on has a huge amount of edema and you're diuresing them, you have to wait for them to stabilize. But once they're stable, if they're continuing to excrete, make up a lot of ascites, and you keep having to tap them, and you check their urine and they're excreting 100, or if the sodium is higher than the potassium, you know they're cheating on their diet. Okay. Why are we so interested in hyponatremia? This was a study from 997 consecutive patients, 28 centers in Europe, North America, South America, Asia, 28 days. Inpatients and outpatients with cirrhosis and ascites. Okay? Here's sodium, greater than 135, 131 to 135, less than 130. Here's your risk of developing these complications. Reference is greater than 135. If you are 131 to 135, your risk of hepatorenal syndrome is up 1.75. It's 3.5 times if you have a sodium less than 130. Same with hepatic encephalopathy. With GI bleeding, it's only the extreme form, and the risk of bacterial peritonitis 2.5 times. So low sodium is associated always with a worse outcome. And so we're interested in low sodium. But notice, well, the thing is, every cirrhotic patient I have has a sodium of 130 or less. And so this was this brilliant piece of work by Kim, New England Journal of Medicine, showing you, here is the MELD score. Remember I told you 40 is 100% mortality. Here is a Utah Sunrise showing you that sodium adds to the predictive value. So if you incorporate sodium in your formula, you can make MELD more predictive. But here's the caveat. If you have a very high MELD, adding sodium to it doesn't make any difference. If your MELD's 40, it doesn't matter whether your sodium's 110 or 140, you still have 100% mortality. But the lower the MELD, the more important this sodium number is. So for example, if your MELD is 20 and your sodium is 125, your MELD is actually about 28. And that is a big difference in mortality. So there is some talk about whether we will be including sodium in MELD in the future as organ allocation. Let me just quickly touch on a couple of other things. So acute hepatitis panel, I see these a lot. Acute hepatitis panel by law has these features: anti-hepatitis A IgM, anti-core IgM, surface antigen, anti-hepatitis C. What it doesn't tell us, what I've put here under the rest, it doesn't tell me if you're immune to hepatitis A. It's not an acute illness, but we need to know, because if you're cirrhosis, you should be vaccinated, and we always send a note back to the primary care saying, please vaccinate. So we like to know that. Anti-core total. I would also like to know if you've ever had hepatitis. So this doesn't tell me that. So we always get the total, and we get the anti-hepatitis, anti-HBS, because I want to know if you have immunity. And then we get viral titers. So if you have a positive hepatitis C, we always like to know what your viral titers are. And there are a couple of others I've put up in there because we're interested, depending on the patient. Sometimes it's hepatitis B, sometimes C, sometimes E. E is becoming more of a hot topic across America. Apparently the Midwest is rife with hepatitis E because they get it from hogs. E antigen is just a truncated form of the core. So when you convert from E antigen to E antibody, it doesn't mean necessarily that your immune system is very robust. It may just mean that you have a mutation over here, and so now you're making a shortened core. You no longer make the E antigen, and so it's a stage in hepatitis B. And you can measure for mutations over here simply by sending to your friendly ARUP lab and saying, tell me about the mutation status of this patient. Autoimmune markers, we usually check for ANA smooth muscle anti-actin. There's a thing there called LKM. LKM is found more commonly in juveniles with autoimmune hepatitis. You cannot have ANA and LKM. Those two never go together. So I don't routinely screen for LKM unless I have a young person. These people, all the ones I've seen, have had cirrhosis by the time they got to their early teens. PBC has a positive AMA, antimitochondrial. Increased IgG is common in autoimmune. Increased IgM is common in PBC, primary biliary cirrhosis. They are frequently AMA positive. PSC, there are no markers, but there is a variant called IgG4 disease, which gastroenterologists all know about. It's also called autoimmune pancreatitis, and about 12% of people with PSC will turn out to have that, and therefore it's always worth checking. Okay. I've put this in your, I don't intend to go through with this. This is how you distinguish between, for autoimmune, there's a scoring system for autoimmune hepatitis. I put this in, it's very complicated. There is a simplified one that has recently been published. And then AMA is positive in about 90% of people with PBC, but there is an AMA negative PBC, and you should be aware of that. Those people frequently have ANA positive. FibroSure, I don't use it. It is available. You can order that from your lab. And the last thing I wanted to use is this case to say, I saw this 49-year-old lady admitted through the ER. This was, by the way, avoiding common pitfalls. Admitted through the ER with jaundice, fever, chills, right upper quadrant pain for 3 days. She said when she drove to the hospital, when she went over a bump, her right upper quadrant hurt. So if it's lower quadrant, that is almost guaranteed to be appendicitis. And if it's right upper quadrant, cholecystitis. Okay, people are thinking, you have to think cholecystitis. Her ultrasound showed a thickened gallbladder. She had a large liver and she had Murphy's sign during the ultrasound. So, does this patient need a cholecystectomy? Everything points to acute cholecystitis. She gave us a history that her mother had gallstones, mother and grandmother. But she also told us that she works from home, and she said she drinks 1 to 2 glasses of scotch a day. Now, I have never met anyone who worked at home who drank 1 to 2 scotches a day. I think it's a general rule. So this lady had acute alcoholic hepatitis, and it is very misleading. And the biggest pitfall I see is people get sent to us. The surgeon panicked. They did a cholecystectomy. Patient comes in, and they frequently die. So their 90-day mortality is very high. And so this is one of the major pitfalls. If I said there was the worst thing I see, it's people failing to recognize alcoholic hepatitis. So in summary, I've told you about ALT, AST, and liver injury. I told you ALT is usually higher. I explained why ALK-Phos, GGT, and 5' nucleotidase are always there. I told you Wilson's has a low ALK-Phos. I told you what AFP is, an analog of albumin. It may go along with regeneration. I've given you this dissection beyond any reasonable tolerance for bilirubin, what's direct and what's indirect. I told you about serum ammonia, the INR higher in zone 3, and I told you that severe liver injury causes hyperbilirubinemia and abnormal clotting. Thank you very much for your attention. I tried to use up all the time so no one would ask any questions. No? All right, thank you very much. Oh, sorry, a question. Oh, right. So the question was, if you just find a high bilirubin and the patient feels fine, the liver tests are normal, we usually call that Gilbert. I think that's a reason. You can actually measure the UDP enzyme, but pretty much if it's indirect bilirubinemia and they have no reason for hemolysis, their blood count is fine, That's all I do. I just say it's most likely. It's so common that we don't really work it up.
Question?
Yes.
Two questions, actually. One, obviously healthcare providers have to have a test done to find out if they have protection against B. There's one doctor I know who's had 5 immunizations, still is 0. Now the ID people say that patient doesn't have to worry. They really have protection even though they don't have the level. Could you address that?
That's a very good question. So the hepatitis B works in about 90% of adults. The younger you are, the better it works. But there are people that fail immunization despite multiple doses. There is a double-strength dose made by Merck called a dialysis strength, and it's concentrated, and so you can give them four times the dose. But there are some people who just never develop those antibodies. Now, I don't believe the ID people. Here's what I would do: if he is hepatitis core positive, anti-core positive, then he was exposed. Real viral immunity is through your T cells, not through your antibodies. And so they're assuming that he has T cell immunity that would protect him. I don't think you can say that because what you've given him is a solubilized antigen, and I don't think it really stimulated T cell function. However, there are other adjuvants. There's a GC adjuvant that may increase his T cell response, and so I'm not sure I would worry. Is he in a very high risk?
No, well, but does travel to and does medical mission stuff out of country. So they're in Bangladesh. I sort of like them to have.
Yeah, I think you could try him on a double strength, but I don't think he has immunity. But I also don't think you get to a point where there's nothing really else to do.
Okay. The other question is Dr. Lustig at UCSF. He's a pediatric.
Yeah, know him well.
Okay. Yep. Of course, bottom line was fructose. 15 grams. You exceed the 15 grams of fructose in your diet. The body has no choice but to put it as fat in the liver and store it.
Correct.
And of course, with the high fructose corn syrup issue, it's a real problem with the thing. Could you address that of why we're not actually seeing more as a public health thing, saying, the science appears to be fairly straightforward in terms of his explanation.
Yes.
Could you address that, please?
Yes. Actually, that was going to be my alternative topic. Fructose is specifically metabolized through fructokinase, and it's a very badly regulated system. It doesn't turn off gluconeogenesis. It activates adenosine deaminase, increases uric acid, increases blood pressure. So it has multiple adverse effects. But so number one, who are we going? If we say stop using high fructose corn syrup, it's the poor farmer. And so the government and the farmers are in this uneasy relationship. It would be very difficult for them to take on the entire corn industry, which is what's producing high fructose corn syrup. I spend an incredible amount of time counseling my patients on avoiding sugars in general and fructose-containing sugars in particular. I believe everything that Lustig has said, and he's not the only one. There are several. Actually, there's a lot of literature to suggest that that's a very bad. That's a very bad nutritional source, and I don't know if we'll see government action, but certainly at the physician level, I'm starting to see more and more people who've come to me with their primary care physician telling them, you need to go on this lower carb diet. And I think it's crucial to beating this obesity epidemic.
Thank you.
And by the way, I'm from Texas, where you guys have nothing compared to us.
Thank you.
All right, thanks.